We have all these people with poor outcomes and high costs, and we are designing them into mismatched services, guaranteeing poor outcomes and high costs. All the while we sit hoping for new money so that we can deal with the weirdos. They're not the weirdos, they're the normal people, and we're never going to get enough new resource to deal with them all. And the more that systems are mismatched to what's actually happening, the less effective and efficient are the scarce resources in producing good results for the people. So we're trying to build something that's about everything. All services are designed to be welcoming and hopeful, empowering, strength-based, and addressing the expectation that the next person or family you see will have multiple issues, and they desperately need to receive an integrated partnership with you. So when we're talking about a whole system, what are we talking about? What is a system? What is the Santa Barbara ADMHS system? One of the things that systems are not is this big ugly monster in Takashi's office somewhere. And we say, oh, well, we want to change the system. Let's find that ugly monster in the county administration building and drag it out, beat the crap out of it. Sorry, I promised Chris I would not say any bad words. Erase that. And then everything's going to be fine. But that's not what systems are. Systems are us. Every system like yours is like a set of nesting Russian dolls that are not quite so nesting. There are systems within systems sitting next to other systems within systems within systems within systems. There is county administration. There are county-operated services. Within county-operated services, there's adult stuff, child stuff, puff stuff. There are different teams in different locations. There are CBO partners. Many of you are CBO partners. Some of you are CBO partners. Every CBO is a system unto itself with subsystems, programs. Some of you are small, some of you are big. Some of your programs are so big you have multiple teams and units, which are subsystems themselves. We have other subsystems. We have the jail. We have homeless shelters. We have housing programs. Every one of those is a subsystem partner that owns a piece of its own responsibility for being about a common set of values. So the challenge of transformational change, which is why it's so important that we all have to do this together, is that transformation is not up here, it's not down there, and it's not over here. It involves every system, every subsystem, every sub-subsystem. It involves all the different programs and organizations. It involves the crisis system flow. It involves the North County flow. It involves the homeless subworld partnership. It involves the criminal justice partnership. Everyone engages in a common process, moving toward a common vision and set of values, with every dollar spent and every policy, procedure, and practice. And in a county provider or a CBO provider, it's the organization as a whole, and within that, every program and every person delivering care. So everybody has an opportunity to contribute in this very big vision, holding structure for the partnership, process to move forward, and things to do. Now, we use a framework, we've been using this for years, called CCISC. Don't worry about that you never heard of it before, that you don't know what the letters mean, it doesn't really matter. The idea is defining the amazing sense that whatever it is you may do as a program, you can be moving in the direction of this vision. Whether you're a psychiatric inpatient facility, whether you're a school-based outreach program, whether you do outpatient substance use in the jail, every program thinks about how do we become better about the customers that we have So we're welcoming the more challenging people. We're in the hope-inspiring business. We're empowering strength-based, recovery, resiliency-oriented. We are trauma-informed. We are complexity-capable because we welcome the opportunity to help people with multiple challenges make progress toward having beautiful, happy lives. We do that. And when we start all talking that common language, and when we come together as partners, we're shifting. As opposed to, we don't do that, you do it. We don't like those kind of people, you take them. We're all in it together. Okay? We love complex people, but we need help. We'll help you with yours, you help us with ours. We'll work as a team, we'll create process that flows. And the people are not left hanging because nobody wants them until they fall into the most expensive level of care. Okay? So this is a big deal. All programs, all persons. Okay? That's what we do. And we call this, for those of you who are familiar with 12-step language, we call this a recovery process for systems. And the reason we do this is because, there's a lot of very complex organizational change theory that we use in helping systems to do this. But we know that most of you are, beautiful frontline people. You're not going to be whiz-bangs in organizational design. But if you understand the process by which individual people go through recovery, and you say, that's what my system has to go through, that's what my program has to go through, the whole thing may make some sense. And you start applying mottos like, progress, not perfection, one day at a time, and say that's what our program has to go through. We have to keep moving and moving and moving. We may slip, but we pick ourselves up and we keep working our program of recovery to keep moving forward so we get where we're needing to go. And when are we done? We're never done. We constantly are moving in our own journey. Okay. So this is a very big deal, okay? And, the notion of doing this, because the first thing that people think, if my program is going to do something to improve, we think, oh, we need more resources. Okay? But everybody's got exactly what you've got to try to do with something for the people who are actually showing up. So one of the things you think in this process is wherever you are, whatever your process is, put the real people in the front. Look at yourself and say, if, when we were invented, we knew then what we know now about who we actually are going to be serving. And we knew then what is known now about how to be helpful, hopeful, and inspiring to people with all these challenges. How would we have organized ourselves, policy, procedure, practice, paperwork, on the assumption that the next person showing up at our door was going to have multiple issues and we needed to be in the welcoming, hope, inspiration, and complexity, helpfulness business? What can we do to improve us? Okay? And that's the journey toward what we call complexity capability. Same thing for individual people. Everybody can do this. Clinical staff, peer staff, support staff. It's not about how many degrees or licenses you have. It's about how you organize yourself with a clear set of instructions provided in your own program to say, what is it that I do to help the next person who shows up with multiple issues so I can be a great partner to them in helping them along their journey. Now, there's lots of stuff to this that I'm not going to go into. And we have tools that we offer systems to help them that Santa Barbara may or may not use, some or all of these. We have system tools and program tools and subsystem tools and 12 steps for programs, which I will address toward the end of this very briefly, and tools for clinicians and 12 steps for staff and blah, 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 blah. There's lots of structure, but we're just kind of getting everybody organized to begin. The question is this the vision that we want in Santa Barbara County? And you sort of sit there and say, you know, sounds amazing, but how would we actually pull this off? And the good news is that we, not we, but all of us have the knowledge right now to know how to make progress in this vision. And you guys are blessed because you have leadership, not us, I mean, we're just helpers. You have leadership who wants to take you there and to use this knowledge to figure a whole lot of things out in a different way than the way they've been figured out before. So the first thing is that there's a set of principles. We know how to do this clinically. Okay? And by the way, I know that people are getting hot and uncomfortable and sitting in the back. So if you're suffering and feeling like, I don't want to get up because it would be impolite, ignore that thought. Just go ahead and get up and be comfortable, okay? Because, okay? So, and then come back, because we're going to keep going. So, because, you know, I love you whether you're leaving or coming or whatever it is. So, but we know how to do this. Okay, there's enough knowledge in the world to do this. And Chris and I have spent a long time looking at all the research, evidence-based practices, this, that, and the other. And you know, when we deal with all of these challenges, and you know this because you've lived this in your own system too. You know, so the first thing somebody says is, we need some evidence-based practice program. I wish we had some money to buy it. Let's go buy it. Okay, and then, you know, you set it up and it's never big enough. A lot of times the people won't go to it, okay? And what we're learning is, yes, it's important to have an array of programs. But in any program, if you start looking at the research and you open the cover of the research that works, this is the conversation we were having before, and you look inside and say, what is it that they're actually doing in this fancy program that helps people? And you pull out the interventions and practices and say, what works? We can figure out what works and organize it so the stuff that works is more likely to be delivered in any setting, by any team, to any group of people with challenging needs. And that process of beginning to apply those interventions and strategies more routinely so that people are helped more smoothly and easily is what we call moving toward welcoming, hopeful, recovery-oriented, trauma-informed, complexity-capable care. And I'm going to go through the principles quickly so that you can see them in a minute. But before that, we also know how to do this organizationally. And that's what this whole system change process is about. What we talk about as a team is using the best practice approach to transformational customer-oriented system change that Takashi articulated so beautifully. And most folks who work in the trenches of behavioral health and human services may not even be aware that there is such a thing. But there is. It's been very well studied for decades in all kinds of industries like Toyota, in hotels, okay, and retail. It just hasn't been brought much into healthcare until the last decade, and barely into behavioral health. And it's a word you've heard. It's called continuous quality improvement, okay? But quality improvement is not the same thing as what it emerges in a lot of systems as quality assurance or compliance monitoring. Compliance monitoring is very important, but it's not quality improvement. Quality improvement is a recovery process for programs, organizations, and systems. And it's not just a single project. It's a way of doing business as a culture shift. It's essentially connected to trauma-informed organizations, because in order to do quality improvement properly, you have to work in empowered partnerships and in safe environments. And you have to put your customers first. And there's a whole technology for doing this. If any of you are familiar with Niatex, particularly in the world of addiction treatment where it's most common, but it's starting to spread in other areas, Niatex is about teaching process improvement, quality improvement, performance improvement as a strategy or a technique. What we're doing is taking this basic approach and powering it up to the nth degree and helping your system take it to the highest possible level, because everybody's involved There's performance improvement everywhere, and you don't stop after one cycle. You just keep moving in the direction of your vision. Now, part of this is creating a partnership. We've been talking about partnership. In order to do quality improvement, you actually have to have a partnership. It has to be structured at all different levels. It has to be horizontal, and it has to be vertical, and it has to be that way at all different levels too. Steering committees, change teams, action teams, all of those things have to espouse the partnership. So the first aspect of the partnership is horizontal. And you heard Takashi do that brilliantly. We, ADMHS leadership, I'm speaking for them, I'm the consultant. We are here to welcome you to join the partnership. We are welcoming our county programs to join. We are welcoming our CBO partners to join. We are welcoming our consumer organizations to join. We are welcoming the Sheriff's Department to join. We are welcoming the Homeless Coalition to join. We are welcoming you. And we want to welcome you exactly as you are, because we love you exactly as you are. Some of you here are excited about this whole process, so much so you can't stand it. You're ready to jump up and say, I want to be the biggest front-running change agent in the universe. My agency is going to be a leader. My program is going to be front and center. We love you. Come on board. Help others to guide the way. A lot of you are, I just want to do the right thing. I don't want to be beaten to death. I don't want to fail. I don't want to get in trouble. I want to be a good, successful partner. You guys are the middle of the pack. You're critically essential. And there are some of you who are internally, as Takashi said, rolling your eyes and going, ah, with every fiber of your being, saying, been there, done that, been hurt before. I don't want any part of it. We get all this invested, we get hopeful, and then we get screwed. And we need you. Oops, I said something else bad again. I can't win. We need you too. We love you too, exactly as you are. That skepticism comes from a deep caring. That voice is valuable at the table because we can't figure things out without it. All you have to do is have any interest in trying to make things better, and you have a place at the table. The other aspect of the partnership is vertical. Okay, you cannot do this from the top down. You cannot do it from the bottom up, and you can't do it from either side. Every aspect of this has to create opportunity for partnership down the levels. Senior management, middle management, CBO leadership, program heads, supervisors. And most importantly, the people who are on the front lines of delivering services, both clinical and administrative, and the people who are on the front lines of receiving services. Because these are the folks who, this is what it's all about. These are the people doing the most work who generally experience the least empowerment of all. So we have to find a way of creating an organized, empowered place. And that's why we came up with the term change agents, because everybody's a change agent in your heart somewhere, okay? But we created the idea of having a team of change agents as a formally designated constituency in a system to be a partnership with leadership. So that every part of the system that comes is welcome to join, every program, every entity, every subsystem says, as a leader, I'm responsible for my contribution of my subsystem, but I need partners from my world to be my frontline change agents to represent that voice with me. And our job is to help bring all those beautiful, energized, excited frontline people, consumers and families, together and help create an empowered change agent team. And what we will be telling the team, if you come this afternoon, or the potential team, is you guys are intentionally empowered individually and collectively to be a boundary-spanning team across the whole county service delivery system, to work in partnership with leadership to help overthrow the established order. And if that's something that makes you go, woohoo, oh, there you go, Art, and boop, okay, if that then you are naturally designed to be change agent genetic material. If you say, oh my God, not me, I'll get killed, but you go, that's perfectly fine. Okay, you want to find somebody, if you're not going to be a change agent, know who your nearest change agent is, because they're out representing the experience of frontline. You can't do improvement without the voice of people who are actually doing the work. But it has to be organized and consistent. And developing these change teams is something that we help systems try to develop forever. Okay, not every system does this, but it can be done. So we started working in San Diego back in 2002, and we stopped working there in 2005, and the change agent team is still going and growing. Okay, and that's something for you guys to have. Now, as we do this, our goal is to anchor the change into the bureaucracy. So one of the things we're passionately weird about, me in particular, is the idea if you have a set of values, they have to find their way into every piece of bureaucracy. So the rigidity in the bureaucracy holds the good stuff in place, not just the stuff you're trying to avoid. And so we spend a lot of time thinking about how do we document in a chart in a way that's inspiring? How do we write an inspiring, hopeful, integrated recovery plan? How do we write regulations, policies, and procedures? How do we write contract language that reflects a quality improvement partnership? And I read regulations, policies, procedures, and paperwork for fun, okay? Because part of what we do as consultants is help systems, as they start moving into this, figure out how to rewrite all the language with the idea that people are at the center and partners are at the center, and every piece of tone has to hold the infrastructure in place that you want. And the final little motto here is what we call, this is a big recovery process. We're inviting you as beginners to the 12-step meeting of recovery for the whole system. And we want to welcome everybody in, provided people come in the spirit of what we call the Serenity Prayer. And the Serenity Prayer goes like this: the serenity to accept the things we cannot change, which is everybody else. The courage to change the things we can, our own work, our own team, our own program, our own agency, our own span of control, wherever we happen to be, and the wisdom to know the difference. And if we all come together thinking, how do we bring our own experience, strength, and hope at whatever level we are, we all start moving together in an organized way, even if everybody changes a little bit, the whole system begins to move a lot, and all of that movement informs the more complex action teams that have to take place to look at all these subsystem activities. Now, this is a big vision, and the starting place for the vision is embedded in a set of principles that we got from the research and help to inform some sort of core values. And I'm going to go through them pretty quickly. The first principle is find the clicker in my pocket. Okay, here we go. Okay, and these are all the system design components. Okay, you can see them in the slide set. Partnerships, all the things we looked through before. How well are we doing? Here we go. Okay, here's the first principle. People with complexity are an expectation in our system. We have to build that expectation in a welcoming manner into absolutely everything we do. So welcoming becomes a core principle. But welcoming is not a principle like, gee, wouldn't it be nice if we were all nicer? Welcoming is literally about deliberate practice development and practice instruction. And if you don't think big, complicated systems can organize everybody to be welcoming, you've never been to a hotel, a restaurant, or even Walmart. Because the starting place for welcoming is the basic technology of customer service. And if you've ever had customer service learning, you know that it's all about how do we welcome not just the easy folks, but particularly the folks who are most challenging. And the issue in behavioral health systems is not so much that we're going to be as good as the Hilton. It's historically we haven't paid a whole lot of attention to this at all. either with the people we serve or with each other. And we're in a business where whether or not people are welcomed and engaged is not about whether they buy toiletries. In our world, it's a matter of life and death. So we start with basic welcoming. Hi there. You're one of those folks who's showing up with lots of challenges. You're hearing voices. You've been drinking alcohol. You're high on meth. You lost your housing. You have no insurance. You're on probation and you're hoping that your probation officer can't find you because you know all these things could get you in big trouble. You don't speak English very well. You know what? You're exactly the kind of person we most need to be serving here, because you're the kind of person who's having the hardest time. We know it's really, really hard for you to show up here asking us to help you. Thank you for coming. You're in the right place. We are really, really glad you're here. We know it's not our job to know how to fix you, manage you, control you, take care of everything in your life in 5 minutes after we meet you. Our job is to get to know you, inspire you with hope, and help you to figure out how to get connected to something ongoing that over time is going to help you with every single one of your issues so that you can achieve the most beautiful, happy, hopeful, successful life you possibly can. Now, there's nothing in that speech that's rocket science. The question we ask ourselves as a system is, how well organized are we right now? Anywhere we organize anything, so that when people exactly like that show up at our door, that everybody knows that's exactly what we're supposed to say by policy, procedure, and practice. And not just reading it off an index card, although that's helpful if you need to memorize it, but saying it from the heart, looking people right in the eye. Whether or not your agency is the best place for them to be in the long run, it doesn't matter. They came to your door. And it takes 2 seconds before we think, hey, we probably have some improvement opportunities that we can wrap our brains around. There's something we call intermediate welcoming. What if we had a little rule in our system that said we don't trash talk about the people we're serving based on their complexity or anything else for that matter, even if they're not listening, any more than we would use racial slurs behind people's back. And you know how easy it is to get frustrated and to fall into that for the people, for the parents, for the whatever. And then there's really advanced welcoming. What happens when people show up at our doors with symptoms in some other domain? They show up at the substance store with mental health symptoms that make it hard for them to participate in care. They show up at any door smelling of alcohol and kind of unsteady on their feet. How do we make it our most important business in that moment that that person feels really, really happy that when they were in crisis, they happened to be in the presence of people who are being paid to help them, rather than thinking our job is to tell them they behave badly and inappropriately, kick them out of there, and hope they don't land someplace too terrible. Okay? So welcoming gets pretty deep pretty quick. Now what's the next principle? Because people will say, okay, we'll welcome people, but once we welcome these people with all these issues, where the heck do we send them? Which is a process that I call welcome and out. So when we welcome people, where do we send them? Well, the first thing we do as a principle is we send them to us, because we're accountable for what we do in the moment with the people who are in front of us. And our job in the moment, wherever we are, whenever we're doing it, is to create relationships with people. Because over time, it's inside the relationship for any moment, and over time that helps people with lots of issues make progress. And we know that it takes time for people to move through their journey of recovery, and they work best when they have good partners who work with them every step of the way. So the next principle is create those partnerships, and those partnerships are empathic, meaning we have a framework for listening to people's stories. They're hopeful, meaning we start and do everything based on what people's most hopeful goals are for a happy life. And we find that in our documentation of assessment, intervention, and planning. They're integrated because we all become partners with people saying, my job is to help you with multiple issues making progress in the direction of your goals. Let me give you an example of this, okay? We're saying everybody starts thinking, I'm in the integrated helpfulness business. Everybody, everybody. So let me ask you this. How many people in this room have something in your job description right now that says, my job is to help people with complex co-occurring conditions, mental health and substance? Okay, how many of you see people like that every single day? Okay, so that's been our historical workforce development strategy. We hire you into a job, give you a title and a description, and we keep hiring the wrong clients for you to work with. Okay. Strength-based. Okay, strength-based is a way of being in a trauma-informed, recovery-oriented system. It's a way of being with people. It's a way of being with ourselves. Strength-based, and you know how we do strength-based normally? Okay, because we all do strength-based because it's a requirement, right? So the way you normally do strength-based is you do your assessment, 30 pages of listing defects to justify medical necessity, and then right at the end there's a little box right before the diagnosis that says strengths. You're not sure what to put, so you write nice teeth, loves plant, friendly smile, plays guitar. Let's go back to the deficits and figure out what we're going to do. But that's not what strength-based is. When we're in the strength-based world, we have to live and breathe strength-based. Terry said to me last night, you know, because she says things and I say, you know, I reframe stuff. He says, you're so strength-based. And I said, well, that's, you know, we live and breathe it because it's an organizational thing too. The way of thinking, one way of thinking about strength-based is everybody we work with is like us. We're all trying to deal with many issues, trying to get happy. Sometimes we do well and sometimes we mess up. When our clients do that, we call them chronic relapsers, which is not terribly inspiring. But in the world of strength-basedness, there's no such thing as a chronic relapser. There are only people like us who are recurrently successful. And when you're in the world of strength-based, you look in detail at the amazing periods of time in the face of all their issues that the people we're working with in all ways manage to do something right and help them recognize how much strength it takes to make little bits of progress in the face of all these challenges, join them in the partnership and say, how do we help you to do it better? And actually, that's the organizational framework of improvement as well. Next principle, all the people are not the same. So everybody's dealing with complexity, but different programs are working with different subpopulations. And we love all of the important people with complex needs. And in a system like this, we don't get caught up in saying these are mine and those are yours and we're going to fight over them. They're all ours. We all have different jobs, and part of our job is to be helpful to others. My job is to help you with your people. Your job is to help me with mine. It's a two-way street. And the way I help is not just by tossing people back and forth across the referral domain. We help people through consultation, education, in-reach partnership, and support, so more people get what they need in a single door, and fewer people need duplicate and parallel services or fall between the cracks. And everywhere you think you have scarce resources and you're retreating into your boundary, you step forward into the partnership and say, how do I help? And then you attract help back, and more people get better outcomes with less resources across the whole county. Which problems are primary? They're all primary. We have lots of people with lots of issues, and what people need is the right next step for each issue at the same time. We call that integrated primary care specific treatment. How do we know the right treatment? Everybody's moving in their journey, but not everybody is in the same place for all their issues at the same time. And there's a language for this. It's called moving through stages of change. So when you meet people in the partnership, you think, I have to meet people exactly where they are. And a lot of our frustration and a lot of our cost comes from beating people into submission, trying to make them do something we think is good for them when that's not what they want, which actually creates a whole lot of frustration on all different levels. We have to meet people where they are and help them to make progress. And if somebody says to you, so we call that stage matching. And if somebody says, what stage of change is somebody in? The correct answer is always for which issue. Because people have lots of different issues and there are different stages for each. And wherever you are, you meet people exactly where they are. And you help them. They're coming to you because you have something they're interested in. You meet them around that and work within that relationship to help them address other issues they may be in earlier stages around. What's the next? Go through this. When we're actually helping people, what we're trying to do is build on people's strengths to help them to learn new skills a day at a time. Practical learning for each issue with big rounds of applause for each step of success. The simpler we make it, the easier it gets. We could spend all day going through one evidence-based practice after another, and we'll help you to understand how these same principles inform them, however neatly they're packaged. Okay? It's really very simple. But the thing we ask ourselves is, let's look at policies, procedures, practice, and service design. Do we start by designing everything around welcoming and hope? Think about your assessment form. When you open that thing up, is it screaming welcoming and hope at you? Okay, no, it's screaming mind-numbing data junk. And you say, why is that? Oh, Medi-Cal requires, state requires, CARF requires, JCO requires. Okay, is there anything in those requirements that says under no circumstance create welcoming, hopeful paperwork? No. So why do we do it? Because we operate our systems in a value vacuum. And if you create a value vacuum, the only thing that fills up your life is the stuff that other people are demanding from you, not the thing that's in your heart. Value-driven organizational design means your values are first, your values are foremost, your values are always. And you challenge yourself that every time you pick up a piece of structure, it reminds you what your values are, because you may be having a bad day and you might forget. Okay? All right. So, there's no one, So what we're trying to do is pull all this together and get everybody involved in the process. Okay, so that everybody starts to come together around all these different domains. Customer-oriented redesign. Putting the stories of real people into how we figure out improvement. Welcoming access. These are all potential action teams that can be started at different points. Peer support expansion. Crisis redesign. A whole continuum of partners loving people in crisis. Utilization management redesign so that everybody can flow smoothly through a continuum of care across multiple domains. Person-centered, team-based, flexible intensity, moving from caseloads to managing populations as teams so that we have more flexibility and capacity to work in partnership with the people we're helping. Managing people who are high utilizers. That's why it's crossed out. Okay? And developing system of care partnerships, housing system redesign with wet, damp, dry housing, okay? And we all take the first step together, which is somewhere we have an opportunity to take this back into our own conversation and say, let's talk among ourselves and our team about how we can be committed to the journey.